anesthesia. A graft is sutured above and below the occluded segment of the femoral artery to restore blood flow to the distal extremity. The graft can be the client's own saphenous, cephalic, or basilic vein, or be made of a synthetic material. What types of complications would you anticipate after this surgery? Complications of femoral popliteal bypass grafting include infection, bleeding, hematoma, deep vein thrombosis, embolization, graft occlusion, and compartment syndrome. As for management, what assessment data would be important postoperatively? You'll evaluate circulation to the affected extremity by assessing color, warmth, sensation, pulses, and pain every 15 minutes, then hourly. To assess for compartment syndrome, note worsening pain and ischemia, and assess fluid volume by monitoring heart rate, blood pressure, and intake and output. Then there's infection. You'll assess the incision for drainage, edema, warmth, induration, and finally incisional pain. Now for the nursing diagnoses. They would be acute pain, risk for infection, ineffective tissue perfusion, anxiety, and fear. The preoperative interventions include documenting baseline assessments of the affected extremity, marking pulses in the affected extremity to facilitate post-operative assessment, and explaining the surgical routines and what to expect after surgery. Your post-operative interventions will help determine whether the client's pain is related to the incision or to tissue ischemia. You'll administer analgesics as prescribed and assess their effect. Use aseptic technique for wound care. Immediately report increasing pain or pain like the client experienced preoperatively, which might mean that the graft is occluded. An occluded graft can be treated with thrombectomy, graft revision, or thrombolytic therapy. Worsening pain also is a symptom of compartment syndrome, a complication in which swelling interferes with blood flow. Administer IV fluids as prescribed and monitor fluid status to achieve optimal hydration. Dehydration invites thrombus formation and graft occlusion, while excess fluid volume places undue stress on the graft. Other interventions are assist the client out of bed and with ambulation when permitted. Advise the client not to sit for long periods of time. Wrap the leg with an elastic bandage as ordered. Encourage a gradual increase in walking distance and educate the client about strategies for preventing clotting, like quitting smoking, avoiding dehydration, and not sitting or remaining immobile for long periods of time. Discuss walking or other exercises to improve circulation. Now let's take a few moments to review blood transfusions. A blood transfusion is the intravenous administration of whole blood or a blood component. Some of the blood components that can be given are whole blood, plasma, packed RBCs, platelets, and cryoprecipitate or clotting factors. Blood transfusions are indicated to restore blood volume after a loss due to hemorrhage or surgery, to restore RBCs and hemoglobin in clients who have anemia, and to provide supplemental deficient components such as clotting factors or albumin. Prior to elective surgical procedures, clients may be given the option of storing their own blood for later transfusion. This is the safest option because it eliminates concerns about incompatibility and blood-borne infections. When clients are given their own blood, it is called an autologous transfusion. The blood can be collected by donations made up to 5 weeks before surgery, or it can be salvaged and reinfused during surgery. When a donor's blood is used, a sample of the client's blood is drawn so that it can be assessed for compatibility with the donor blood. This is called a type and cross match. Whether blood will be compatible depends on the antigens present. The red cell antigens in human blood are types A and B. A person can have either A or B, both A and B, or neither A nor B. This is the basis for the classification of individuals by blood type. People can produce antibodies when exposed to foreign antigens. This antigen-antibody reaction can damage red blood cells in a process called hemolysis. Donor and recipient blood must be matched to try to prevent antigen-antibody reactions. The type and cross-match is done in the blood bank to assure that the recipient's blood will not produce antibodies against the donor blood, thus causing a transfusion reaction. Type A. A person who has only type A antigens will produce antibodies against B antigens, so these two blood types are incompatible. Type B. A person who has only type B antigens will produce antibodies against A antigens, so these two blood types are incompatible. Type AB. A person who has both A and B antigens will not produce antibodies against either A or B antigens. This person is called a universal recipient because he can receive any ABO blood type and will not have a reaction. Type O. A person who has neither A nor B antigens will produce antibodies against both antigens, but can donate blood to any recipient without triggering an ABO reaction. The presence or absence of the Rh factor makes a person either Rh positive or Rh negative. A person who does not have the Rh factor produces antibodies against it. Therefore, if an Rh negative person is given Rh positive blood, there will be an antigen-antibody reaction. A person who is type A, B, AB, or O can be either Rh positive or Rh negative. People with blood type O negative are considered universal donors because they have no ABO or Rh antigens to trigger reactions. People with blood type AB positive are considered universal recipients because they have A, B, and Rh antigens, so they do not produce antibodies against any of these antigens. Despite the laboratory checks, a variety of reactions and complications can still develop. Transfusion reactions and complications can be classified as acute hemolytic, antibodies attack antigens on the recipient's RBCs, causing lysis of the cells. Signs and symptoms are chills and fever, low back pain, tachycardia, tachypnea, and hypotension. It can lead to shock and death. Febrile non-hemolytic. The recipient is sensitized to a component of the donor's blood. Signs and symptoms are chills and fever, headache, flushing, muscle pain, and anxiety. Mild allergic. The recipient is sensitized to the plasma proteins in the donor's serum. Signs and symptoms are flushing, pruritus, and urticaria. The recipient's antibodies react to the donor's IgA proteins. Signs and symptoms are urticaria, wheezing, and anxiety. It can lead to shock and death. Septic. The blood or blood product is contaminated with infected material. Signs and symptoms are chills and high fever, vomiting, diarrhea, and shock. Circulatory overload. The recipient's blood volume expands too quickly for the heart to handle. Signs and symptoms are dyspnea, crackles, hypertension, tachycardia, neck vein distension, and headache. It can lead to heart failure. When administering blood or blood products, be sure to watch for each type of reaction and take appropriate action. We will now review those actions as part of discussing nursing assessment and management of clients receiving blood or blood products. Before administering the blood or blood product, verify that you have the correct blood and unit number for the client according to agency policy. This usually requires that 2 RNs validate that both the blood and the client are correctly identified. Check the unit's expiration date. Be sure the blood type of the product is the same as that of the client. Be sure a signed consent form has been obtained. Tell the client to report signs and symptoms that developed after the blood transfusion is started. Document the client's current vital signs. Now, the interventions. To prepare the blood for administration, select at least a 19-gauge catheter. Select a blood administration set with either single tubing or wide tubing and close all